everybody.
Welcome to the show, everybody. We're learning new truths about coronavirus every single day, but there's still much to uncover, especially when it comes to treatment. Now, a common medication used for head lice is being touted as a COVID wonder drug. But is it?
Ivermectin, the latest drug in the fight against COVID-19 that's getting renewed attention. It's not a new drug. In fact, it's been around for 40 years and billions of doses have been distributed globally. Originally introduced as a veterinary drug, it soon made historic impacts on human health, even earning a Nobel Prize in medicine. It's an FDA-approved anti-parasitic drug, but also has strong antiviral activity against viruses, which is one reason it gained attention in the battle against COVID-19. Proponents cite a number of studies that prove its efficacy and safety, but critics are not sold on it being a COVID wonder drug and say the available ivermectin studies are flawed. So, should we wait for solid clinical trials that could take years before prescribing this to people? Or should we throw everything but the kitchen sink at COVID to potentially save lives?
We're so happy to have Dr. Orden. Hey, Drew, what's up, man?
Hey, glad to join you today, Dr. Ian.
Hey, Drew, we got a great show, man. In fact, I want to bring in right away a pulmonary and critical care specialist who's established a protocol for the use of ivermectin to fight COVID. Dr. Pierre Kory, thank you for joining us.
Hey, thanks for having me. Good to be here.
Yes, also joining us is critical care specialist who is more skeptical of the drug's viability, Dr. Ebony Hilton.
Hi, it's nice to see you guys.
Dr. Pierre, let me start with you. You've testified before the Senate, and you've put everything on the line when it comes to talking and touting the benefits of this drug. Why are you so passionate about this medication?
Because I'm just so hopeful. The data behind this medication is now overwhelming. We have identified and uncovered a really effective medication. And so I feel responsible to let the world know about it.
Well, as you know, ivermectin is not, typically used in this particular situation. So how was it discovered to actually be able to treat and maybe prevent COVID in the first place?
Well, so first of all, it's a very well-known drug in treating parasitic diseases. In fact, it won the Nobel Prize for its discovery and its global impacts on public health. So it's well-known in that class of diseases. But in COVID in particular, it started back in March or April, where a group of researchers in Australia did a sort of laboratory bench study where they showed in a cell culture model treated with ivermectin that it basically eradicated the presence of the virus within 48 hours. And so that was the first thing that brought attention to its possibility that it might work in humans. And then a few months ago, we started to see some trials emerge around ivermectin against SARS-CoV-2 clinical trials. And we started to see this really profound data signal of benefit. And I've immersed myself in the data since, and we now have just overwhelming mountains of data showing how it works.
Well, Dr. Hilton, you're not alone. You're like others in the medical field. You say that the research collected on this drug, however, does actually not justify its use for COVID. Different than what Dr. Kory is saying. Explain your position and why you have it.
I am cautious to rush to judgment because we saw the same thing with hydroxychloroquine. We saw the same thing with convalescent plasma, remdesivir. At this point, what we need is to instill trust into the community is tried and true tests. And what is that? That's prospective studies, double-blinded, randomized with treatment and control groups, so that we can try to match as many variables that come with the person, right? Are we looking at people with chronic kidney disease and chronic liver disease? Are these 100 million Americans with these pre-existing conditions? If we put that medication and take it out of that cell culture and into that person, what will be the impact on that person's life? And that's what I'm looking to see.
So what would be the harm, maybe, to add ivermectin to what we already have in our arsenal? I mean, yes, it'd be great if we had the time to be able to have these long prospective studies. We don't really have that kind of time for obvious reasons. So adding it to the arsenal, why is that a bad thing?
Right. I mean, the same thing could be said with hydroxychloroquine, for instance, right? That was the same argument of, why don't we just add this agent? What do we have to lose? But when that double-blinded study came out, Act 1, right, what we saw was that it increased mortality And this is what I want to be cautious about. Like I said, I want a miracle drug. I want my family, I want myself to be able to take something prophylactically. But if the studies come out, if we do what we are trained to do as scientists, if we look at the numbers and at the end of the day, it shows there's a benefit, fantastic, let's do it. But if it shows there's any increased risk that associates with a person's life, every person that dies from it, they meant something to someone. And so we need to do our due diligence to make sure that it's as safe as possible for everyone.
So I have to be clear that, this isn't a belief of mine. This is all driven by data. And I agree with my colleague that we need data. The thing is we need to, this is my job. I'm here to disseminate the data that's uncovered. I think so few people know exactly how much data we have. Right now, in my manuscript, which just passed peer review in a very prominent journal, will be published in 2 weeks, I cover 27 controlled trials with over 6,500 patients. 16 of them are randomized controlled trials. 5 of them are double-blind randomized controlled trials, and 1 is a single-blind randomized controlled trial. So when I hear people asking for randomized controlled trials, I point out we have them. We have thousands of patients in them, each showing remarkable, reproducible, consistent benefits in terms of reducing transmission, reducing deterioration, hospitalization, and reducing death. We don't have any other drugs that do that. And to lump ivermectin in with those other therapies is exactly backwards. Hydroxychloroquine was adopted widely throughout the world with 0 clinical trials to support it. In fact, it was used widely, and I agree with my colleague, it actually did show harm in some subgroups. But then the trials showed that it didn't work, and then it was abandoned. And then the other thing was convalescent plasma, same thing, adopted widely with no evidence. It doesn't work. Even remdesivir doesn't work. And so ivermectin is completely different. We are sitting on a mountain of data, and we're not using it. And I think it's in reaction to all of those prior mistakes.
Again, when we're coming forward with information for the public, and we're saying, we want you to trust us, that means we have to check every box. And at this point, even if we're looking at these clinical trials, they exclude a lot of people, one of which is me. I'm a woman, and they're excluding women and pregnant women from those trials. A lot of the studies also excluded people with renal disease. They excluded people with cirrhosis. And unfortunately, in the United States, we have 100 million Americans with pre-existing conditions that have chronic kidney disease, that have chronic liver dysfunction, that have hypertension and heart failure. And so are we comparing apples to apples or apples to oranges and hoping that those two fruit mix?
I need to respond to that because it's completely irrelevant what she said. That applies, what she just described applies to every research study ever done known to man on any drug. All of those patients are always excluded until you have sufficient efficacy and safety data. So ivermectin ivermectin is not unique in that regard, and that should not be considered less than. The second thing is there's this immense amount of data showing a preventive, so it prevents transmission. And so we have a protocol where we prophylax patients, so high-risk patients and or those who just got exposed. So if you have a household member who falls ill, from numerous trials, if you put the household on ivermectin, very few actually contract the disease. So we have a protocol for prophylaxis, post-exposure prophylaxis for high-risk patients or healthcare workers, numerous trials showing that if you're on ivermectin, your chances of getting it actually approach 0. I mean, there's one trial from Argentina where they did 1,200 healthcare workers, 788 took ivermectin once a week, not one got sick. In the 400 that didn't take it, 58% got sick. So there's prophylactic data, and we have a protocol for that. There's also a whole other host of trials on early outpatient mild illness. Patients are getting better quickly. They're not going to the hospital. And so we have an early outpatient protocol there, which is daily, minimum of 2 days, maximum of 5, but stop when you feel better. Many patients are feeling better within 2 or 3 days, which means they need 2 or 3 doses. And then we have part of our Math Plus hospital protocol. We have a daily dose of ivermectin once a day for 5 days, and we're seeing remarkable recoveries. The patients are telling me, Doc, I took the pill in the morning, and by nighttime, my chest felt better, my fever went away, and the next day they feel better. I mean, it's truly a very, very potent medicine.
Yeah, I want Dr. Hilton to respond to that.
Yeah. Again, I want a miracle drug, but I look at everything from a fine-tooth comb because I understand if I say it, my family will jump and want to do it. And so I want to make sure I do my due diligence. But in looking at who actually tested positive in that group in the Argentina study, The majority of persons that tested positive was 11%, I think, that tested positive in the control group. But 78% of those that are in the control group were women, which makes me think, if those healthcare workers are women, do they tend to be the nurses then? And are they in close contact with that COVID-19? Like we know our nurses are, they are fantastic in their bedside manner. But is that the reason why they ended up contracting the disease?
Well, Doctor, so hold on. Let me suggest this maybe. So, Dr. Kory, she's saying that, you know, certain groups were not included in the trials. You're saying that the trials are showing benefits. Is the answer then the recommendation to just use the drug for those who are actually in the trials? Would you both agree to that?
That's not how medicine works. So first of all, she's overstating who's not in the trials. There's many, many, many different trials done. They're not always excluding those that she said. There's no reason to exclude anyone with liver disease or kidney disease. It's one of the safest medicines known to man. That's why it's on the WHO's list of essential medicines. It's been given 3.7 billion times. It has an unparalleled safety profile. So to have concerns of whether you can give it to patients with comorbidities makes zero sense. We have more history and knowledge of this drug in treating disease in medicine than almost any other. 3.7 billion doses. So to throw up concerns about this patient with this comorbidity and that patient, that's never been demonstrated in the 40 years we've been using it and in the billions of times that we've used it. So I don't understand that concern.
Okay, Dr. Kory, let me let Dr. Hilton respond to that because this is very important.
But when I'm looking at the ICON study out of Florida and it excludes pregnant women, what do I say to my cousin who is pregnant? And that is an exclusion criteria that's used.
I've never heard of any trial with a pregnant woman in it.
But this is not
in any trial.
But this is, again, we're talking about giving ivermectin as a prophylactic, correct? So that means we're saying to people that we are going to say this is going to be safe for you to do. And yes, we have to do something. But the things that we can do as a population that would not make any risk to persons, regardless of their pre-existing condition, are the simple things of wearing masks, to wash your hands, to avoid these large crowds, and that has a better efficacy than any drug that we could ever do.
I haven't thought about ivermectin since medical school, and I know its use is primarily in treating various parasites, worms. I mean, Dr. Kory, when he says that billions have gotten this drug and it's safe, I mean, that's pretty compelling. Of course, there's a burden that you want to know everything you possibly can for the use of this medication in all different patient populations. But at the same time, people are dying. And for that reason, okay, maybe you're not going to give it to a young child. Maybe you're not going to give it to a pregnant woman. That's a different scenario. So I'm a little more open-minded. I understand 100%, Dr. Hilton. We need that information, but in the meantime, Dr. Kory presents a pretty compelling story for this drug. And, you know, if I could just ask Dr. Kory, there is one question. You know, we're hearing all these great things about ivermectin. There could be a concern that people might try to get their hands on the veterinary version of this drug, which is out there a lot because animals get these parasites. Obviously, you're going to advise against this.
Yeah, no, we can't advise to take the veterinary version. We don't have the safety data for that. No, what our whole goal here is to disseminate the knowledge of its unparalleled efficacy. It is going to be a major contributor to ending this pandemic. It's going to be another tool in the toolkit, along with the vaccines. We think it's a bridge to the vaccines. We need our public healthcare leaders and agencies to provide the guidance, and they need to start ramping up and preparing because this drug will be proven. I want to make one last point. On these call for randomized controlled trials, you will harm patients if you keep doing more trials when we're sitting on this amount of evidence.
Dr. Hilton, Dr. Kory, Drew and I agree. We all four agree that we want to be able to find something that works and that it works for as many people as possible. So we hope both of you actually are correct and that it bears out for the subsets that haven't been tested and Dr. Kory for all those who have been tested. So thank you guys so much for a very spirited and important conversation.
I live, eat, and breathe this stuff. It's going to end the pandemic, guys. You heard it here first.
All right. Stay right there.